Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. Whether it's on assembly lines, in space exploration or farming, robotics is making headlines around the world. Modern day surgery is no exception. Since the first robotic surgery system was launched in the year 2000, they've spread to over 4,500 hospitals globally, including over 70 in the UK. To discuss where the field is today and where it could find itself in the future is my guest today. Dr. Mark Slack is a consultant surgeon at Addenbrooke's Hospital and also the co-founder of CMR Surgical, a medical robotics startup based in Cambridge. We discuss the merits of robotic surgery for patients and surgeons alike, potential risks associated with it, and the challenges in developing robotic surgery systems. What exactly is robotic surgery and how can it be used? How could better monitoring improve surgical outcomes and teaching opportunities? And what should we make of suggestions that surgeons could operate 1,000 miles away from their patients, or even that surgery itself could be automated? So, Dr. Slack, thanks so much for joining me today.
It's a pleasure to be here. Thanks for inviting me to join you.
So, to start off with, could I just ask, what exactly is robotic surgery? What do we mean by it?
So it's robotic assisted minimal access surgery. So minimal access surgery, which the public like to call keyhole surgery, is doing all your surgery through small incisions in the abdomen, using quite complex instrumentation to achieve the surgery. Robotic surgery is using a robotic system to drive those instruments rather than a human. And the human involvement is sitting a few yards away from the patient, driving the instruments from a console.
So to be clear, we're not talking about robots acting autonomously, doing operations.
Absolutely not. No, the surgeon is 100% fair and square in control of everything. And these are just robotic arms, so it's a robotically assisted surgery, but it's performed by a human surgeon.
So that leads us nicely onto what can a robot do that a human perhaps can't do operating in first person?
So in minimal access surgery, the instruments are straight and they're long. And it's difficult to always describe this on air rather than on television. But when I move my hand left in minimal access surgery, the instrument moves to the right. It's also a two-dimensional image that I'm watching. And things like depth perception and reach are quite difficult. And in fact, when you get to more complex tasks like tying a knot with suture material, it becomes extremely technically difficult. What the robot does is it's got an articulated wrist. That together with the movement of the arm gives us 7 degrees of freedom. And the robot also, if you move your hands to the left, the software has been programmed so that the instrument moves to the left as well. And it's 3-dimensional magnified imaging, so all the depth perception problems disappear. So we can take a person and get them to a level of proficiency far quicker than with a manual keyhole surgery technique. The other big thing, of course, is that with keyhole, surgeons stand in quite difficult positions, causing a lot of discomfort and pain, and in fact injuries as well. And the robotic system, because they're sitting at a console neutrally and we have clutching mechanisms to move the tips of the instrument, means that we reduce the pain and discomfort of the surgeons, hopefully extending their operating lives.
And presumably you could also do perhaps far finer surgery, as a surgeon might move their hand 10 centimetres and an instrument might move 10 millimetres.
We can actually scale the movement as well, so we can have slow, medium and fast. So for very intricate work we can slow it down, which gives more precision. But because of the combination of the depth perception, the articulation, yes, we think we can do far more precise procedures like suturing very, very small vessels and so on. Yes, so there's an enormous degree of enhancement of surgical ability.
And what sort of surgery is currently carried out robotically then?
So there's only one robot on the market at the moment, which has been around since 2001, and the vast majority of its surgeries are urology. So that's a community that moved from open surgery direct to robotic surgery and sort of bypassed the minimal access, because the particular operation they were doing, which is a prostatectomy, is particularly difficult to do with straight stick because of the suturing. So the vast majority of urological procedures are now done by the opposition robot. They also do operations across a whole range of specialties, but in truth, only 5% of all minimal access surgeries are done robotically.
So What advantages from a patient's perspective? We've heard that it might reduce pain and discomfort for surgeons as well, but if you were a patient having a robotic prostatectomy versus a laparoscopic one, for example.
The advantages are not dissimilar to what we were talking about a few seconds ago, and so I'll go back to that as well. Our system has been designed to be versatile, and we anticipate that we will be able to operate in urological procedures, gynecological procedures, kidneys as well as in the pelvis, bowel surgery for colorectal surgery, upper GI, operating in the stomach, the gallbladder. We also can operate in the chest and the head and neck as well. So in the world at the moment, in 2015, a study in the United States showed that only about 30% of surgeries are done by minimal access, despite all the advantages of minimal access. So to answer your question properly, you've got to go right back. Minimal access surgery reduces by half the majority of complications. And good examples of that are surgical site infections. If you have an open wound, a large wound for an open operation, the wound complication rates cost the European economy 18 billion euros per annum. Now, the reason for that is that if you have a big cut and you get an infection, 50% of those patients will require readmission to hospital, and 12 to 20% will require reoperation. With minimal access surgery, virtually no patients even need to go back to hospital. They can be treated as outpatients. So massive savings in the form of billions of euros. Another disadvantage of open surgery is that about 20% of patients who have open surgery will have to have a further operation for an incisional hernia sometime in the future. And with minimal access surgery, we reduce the risk of an incisional hernia to just about zero. So the real advantages are giving more open patients minimal access. What advantage a robot gives over minimal access is a moot point. A very good minimal access surgeon will not get a lot of benefits from the patient point from converting it to robot. But as I've said, we know that we can only train a certain percentage of people to do minimal access well. So the robot, therefore, will be democratizing it almost by making it more available to more people. We're starting to see signals that there's less trauma and there's less pain with robotic surgery rather than with manual. And that's probably because the robot controls the instrument. There's no tugging or pulling. And that may be something that further enhances its... so then the patients get less pain. And don't ever underestimate what that means. You know, we live in both Europe, England, and the United States in the face of an opiate epidemic. And so if we can reduce pain and reduce the need for opiates perioperatively, we massively advantaging, giving the whole health system a real support.
So I guess this all begs the question of actually why more surgery isn't done in a minimally invasive way.
Oh, absolutely. I mean, there's a popular American surgeon author called Marty Makary, who is a pretty fine physician who's written a few books on this subject, and he's also a person who's being considered as a candidate for the Surgeon General of the United States, and he writes very eloquently on the scandal of patients having open surgery when they should be having minimal access surgery.
And I guess there must be some downsides to robotic surgery, and one of them, certainly with the Da Vinci system currently, is cost. Why is this so expensive?
Well, the current robotic systems available certainly are expensive. Having said that the health economics are very poorly worked out around minimal access and robotic surgery. So when people do health economic assessments of minimal access operations, they normally only follow them to about 6 weeks post-op. Some for efficacy studies, but they don't really do the health economics 1 year, 2 years, 3 years down the line. They don't always take into account the wound infections, the hernias, the complications requiring to go back to theatre and so on. And there are quite a few new studies now looking at even surgery with the Da Vinci, showing that by converting it to minimal access, by reducing the complications associated with open, the cost actually starts becoming very comparable. Having said that, we believe in value-based healthcare as a company, and so we have specifically tried to position our system to cost the same as current minimal access surgery. And that is our aim, and we're pretty close to that already.
Obviously, the incumbent in the market, Intuitive, who make the Da Vinci system in over 5,000 hospitals worldwide, you're competing with them at CMR Surgical. So what do you hope to do differently from them? We've heard about cost, but is there anything else that your system, the Versius system, hopes to do differently?
Well, everything. We're not actually competing with Da Vinci. They occupy 5% of the minimal access market, and they have a market capitalization of more than $60 billion. So it gives you a concept of the size and the scale of the surgical market. They would never be able to completely monopolize the surgical market, nor will any company in the world. There's space for 5, 6, 7, 8 or more players, all of whom can be profitable companies making robots. We're completely different. Ours is smaller, it's modular, it's more easily transportable, and it's very easy to teach and use. So one of our real advantages to a hospital is that if I was doing a case with my robot and I did the first case of the day and our second case is not robotic, I can just move the robot up against the wall in the theatre, and it's so small that there's still space to go on operating comfortably. Alternatively, the person in theatre 2 might want the robot after me, so when I'm finished we move it next door and the theatre next door does it. So that's a real advantage to the robot, so portability. The other thing is that our robot enables surgeons to do the surgery pretty much as they do their normal laparoscopic surgery. So port positions, even the ports they use can be the same. So the adoption is facilitated because of the similarities.
And certainly an interesting statistic is that Da Vinci currently makes over half of its profits from instruments, many of which they mandate can only be used once. Are the instruments going to be cheaper, for example, in the future with the Versius system? And are you looking more towards perhaps recycling things?
Well, I think Da Vinci does use the instruments more than once. They have a lifespan, and I don't think that's entirely due to the companies just trying to make profit out of it. Articulated instruments are exceptionally complex. They've got pulleys in them, they've got wires in them, the wires stretch, the wires dislodge from the pulleys, and the lifespan that is put onto an instrument is largely to do with its safety. And we will put a lifespan onto ours as well. So we're aiming for about 13 lives on an instrument. But that's not because we're trying to maximize profit. It's because we're trying to maximize safety. If we find that we can make it work for 15, 16, 20 uses, we will. But we don't sell ours as a capital up front. We sell ours as a managed care service. So that is predicated against the number of cases they do per annum. So they know what they're paying per case, and therefore the actual number of lives that the instrument's getting is irrelevant largely. It's almost like they have a subscription service. And as long as they're doing the number of cases that they've set out to do, they know exactly what the costs are, and they know hidden costs coming to sting them down the line.
So I think what you're saying is that a hospital wouldn't have to put up a huge upfront cost to buy a robot, but
Yes.
they could almost lease it for...
I mean, each hospital is completely different. So some hospitals may well have capital funds that they want to spend, in which case we would go along with an agreement that allowed them to have a capital spend plus then a degree of managed service. Our preferred model is to sell it as a managed care service, so that they don't have to lash out an enormous upfront capital cost, and they know what they're in for on a per annum basis according to the complexity and the number of cases they're doing. And that's that's different from what most companies have done, but everything we do in this company is different. Our research has been different. The way we keep a registry of all the complications and all the outcomes, nobody else has done that before. So I can tell you now exactly how many cases we've done, what complications have occurred, how long they've been in hospital, what their blood loss was, etc. And we hope to have a data set in the too distant future of a couple of 100,000 cases. Into that we can embed studies. So we will be writing up all the stuff that we do so that the public have a very clear idea about what the advantages of our system are.
And the Versius system has currently been licensed in Europe. Do you have any plans to bring it over, I assume, to America, where
Sure.
the market is far larger?
So we've got a CE mark, which enables us to operate in the UK and Europe. Obviously, that was our target market in the first instance. We then also have it's been licensed in India. We've got it ready to be licensed for Australia, and I'm in the process of going through the American FDA process, which is a slightly different one. It's also changed in recent years, so we've had to modify, but it's all going very well so far. So we are positive that we'll get our FDA agreement quite soon.
I was interested by what you said earlier about there being space in the market for half a dozen or more medical robotics companies. Because surely Intuitive, for example, the incumbent, would also look to enter these markets as well. And Johnson & Johnson, in a partnership with Google, are also entering it as well. And to what extent are you keeping an eye on what other people are doing?
Yeah, no. I'm as one of the founders and the chief medical officer, I promote a culture that we just keep an eye on ourselves and try and build the best possible equipment and do everything in the best possible way. So our primary focus is patient safety and providing a affordable, effective system that promotes and enhances healthcare. And I believe if you get those right, the rest follows. So I'm not particularly, I don't spend a lot of time watching the others. Google are out the equation now because J&J have bought them out. So that's a company called Verb. There's another one called Aurus. There's another robot from Germany that's been CE marked recently. And we know of others that are coming onto the market. But as I said, I mean, the surgical market is absolutely enormous. And I don't believe that even Medtronic, J&J, ourselves, Aurus, Intuitive could provide the wherewithal for all the minimal access surgery just from those companies. It's just too big. So I'm comfortable with this space for all of us. But what I am sure about is that doctors and patients are discerning. So we've got to build a system that actually is safe and reliable and does what it says on the tin, and that's what we're in the process of doing. So I meet with the chief medical officers from the other companies at meetings, and we have a perfectly respectable professional relationship with all of them.
I can see you smiling here talking about it. Mm-hmm. So what exactly, you are a consultant gynecologist from South Africa. What exactly motivated you at the beginning to enter this endeavour, really, to build a surgical robot almost kind of out of the blue?
Well, so I've been an academic consultant most of my career. So as you correctly say, I trained in South Africa to postgraduate level. So I did my undergraduate degree in Johannesburg and then my postgraduate degrees in Cape Town. And then came to the UK to get a bit of a sort of a trial of a different health service and met up with the people, did some research. It got a bit of attention, came to Cambridge. I found that a nice place to be, and I've worked at Cambridge pretty much ever since. And I was on the staff of the university as well, and I've just thoroughly enjoyed my time there. During my career, I have invented a few products, and I've introduced new operations, all of which were taken to global launch. And one of the operations, in fact, is now the most commonly performed operation in the world for prolapse. And so I got a taste for that side of medicine, which is different. But the exciting thing about it is it means you're having an impact on a greater number of people, on their lives, and improving it. And what I was starting to get to the concern, I ran the minimal access training unit at Cambridge for about 20 years, and I came to this conclusion that not everybody could attain the skills required to being a competent minimal access surgeon capable of doing all the complex operations. So I was then looking for something that would enable me to bridge that gap. I met another Cambridge graduate who's a physicist, and he felt he could do that. And four of us got together to try and put this together. And in fact, we're all still in the company, and we're still friends, and we are having a great time doing it. So this is, I've also done a lot of other research, academic research, and published a lot. And I also did a lot of medical legal work in the United States, looking at when things go wrong by companies not having done the appropriate research and background. So there were many strands that I wanted to bring to this. One was to design a fantastic product. One was to do it responsibly and ethically, and 3 was to bring it to market in an affordable and ethical fashion. And so our aims are multiple, but it's great fun.
So you mainly see robotic surgery, therefore, as facilitating a transfer to minimal access surgery where it wouldn't necessarily be possible due to skill, not necessarily due to the type of operation being done?
Yes, correct. So, I mean, minimal access surgery really took off in about early 1990s, 1994. It was accompanied by a range of disasters as untrained surgeons took it on, experimented, and then good training was introduced and minimal access really came into its own around about 2000. So if you look at a normal adoption curve, and there's a wonderful marketing book called Diffusion of Innovations by Everett Rogers, and normally 10% is the sort of tipping point when people start, and you go from the innovators and the early adopters going to the early majority or the late majority using something. And so if we're only doing 30-40% of minimal access surgery in the world, of surgery by minimal access, that means we've gone past the tipping point, but we're not accelerating up the curve. So there's something else holding it up, and that's probably just the difficulty. So hopefully the robot will be the tool that enables minimal access surgery to become universal.
And I guess another question that many people have asked is what happens perhaps when things go wrong in these scenarios? Is open surgery still required? Are we perhaps going to have doctors who aren't necessarily as experienced in open surgery for when mistakes are made?
So there's a very famous French minimal access surgeon called Arnaud Wattiers, who's quite one of the more skilled surgeons I've ever seen in my life. And he was asked this question at a congress, and they said, and he said, well, if I get called to a case that has a problem, and it is an open case, I ask them to close it first so I can fix it laparoscopically. So I think we've moved on so far. The levels and complexity of surgery that's done by minimal access surgeons now, they pretty much can get out of 99% of the problems with minimal access surgery. If the worst came to the worst and they have to open, there are still many operations that are still done open, so there's still a significant pool of surgeons who would be able to help with that. But I think that's almost a throwback to the early days when people were struggling to do the minimal access surgery. But good laparoscopic surgeons, they can fix their complications.
And on this podcast, we quite like to talk about the future. So we talked about facilitating minimal access surgery. But could we go even further than that and actually improve it, for example, because we've got a screen with a doctor looking at it, carrying out surgery. Could there be a role for, say, image recognition and artificial intelligence here?
Yeah, so, you always make me smile when I hear the term artificial intelligence. It's bandied around, most especially by government ministers and so on. And I was interested to see that the person who won the Alan Turing Prize for computational skills last year, which is the Nobel Prize for computers, said that in terms of sort of intelligence, AI has got the intelligence of about a 6-month-old baby. It's computationally very powerful, but it's interpretively quite weak. So yes, but we are obviously machine-aided solutions is what I like to use, and there are plenty. So for example, we have a registry. So if you're using my system, you'll know what your results are. You'll be able to compare it with all the other surgeons using it in the country and in the world. So that's a sort of a marker of quality immediately. We have systems. One of the things that has made a major difference in surgery is the WHO checklist, which is the checklist used. Now, if people do a checklist, just asking a couple of basic questions, they reduce the morbidity of surgery by 47% and the mortality by 35%.
Even simple things such as, have we got the right patient?
Correct. Have we got the right patient? Are we operating on the right leg? Is it the correct operation? Now, one of the things I envisage in the very near future is that checklist will be on our screen, and you won't be able to start surgery until you've been through the checklist. And then the checklist can be semi-automated as well, because it can be checking that the patient data entered fits with what we're talking about. So that would be a great example of something there. We can also put in steps where we can warn. So if you're going to take the instrument out, a warning can come up on the screen saying, have you straightened and corrected the instrument ready for removal? And so it goes. We've already put in one particular bit, because it's got an articulated risk. When they go to press the button to change the instrument, it automatically self-corrects. So then you don't even have to put up a notice to warn the people. And pattern recognition is something. So every single movement that our robot performs is measured by a telemetric system. So I will be able to tell you how many times you moved your hands in an operation. And already we're using it when we've seen things that have been different from the norm. We've been able to look at the telemetry and see whether it was the surgeon's fault or our machine's fault. And glad to say it's mostly the surgeon's fault. But you know, we can put all those sort of things into it. We can put warnings in from the telemetry where a sign can come and say to a person, you're going too close to something. We can put enhanced imaging in, so we can use fluorescent dyes to identify key structures so that you won't damage them. I envisage that things like suturing could be automated at a point. So yes, and we've already got design changes in our head for the next version of the robot, making it smaller, more versatile. And then the other thing, which is in that machine augmented environment, is virtual training. So we have a virtual trainer we've built, and I anticipate that virtual training is just going to grow and grow and grow. So the day that I'm looking forward to is where the surgeon can do online training, then do virtual training, then operate on a cadaver, and when they go live on a human, they're pretty much skilled already, rather than see one, do one, teach one.
And are surgeries done robotically recorded? So could you look back and pinpoint perhaps where a mistake was made
so
within this for training purposes as well?
So yes, we record every single surgery with our system. Now, one of the problems with recording and storing is the storage. So you get into storage capacity needed. So we need to work out a way of storing and cutting out the irrelevant steps and keeping an eye on the important things. And I was at an AI conference on Friday in London, which was attended by people from Harvard, London, etc. A lot of very advanced robotic users. And there's another problem, which is a medical legal problem, is hospitals are very reluctant to leave stored videos of operations because it makes the medical legal output that much easier. Personally, I have no problem with it. I think it's honest and transparent. And we saw an incident with in one of our cases where a tip of an instrument came off, which was retrieved, and that was fine. Within 2 hours, I knew that when they removed that instrument, the tip was at 50 degrees pitch. They hadn't straightened it, and I knew that they'd exerted 43 newtons of force to pull it out, and that had pulled it off, so it was 100% user error. So I could feed that back to the team. I could also show to them on the video. Now, with morbidity and mortality meetings, people very often have to speculate and guess, and yet when we review any cases that have had complications, we know exactly what's gone on because of all this data that we collect here. And then, of course, we have this clinical database backing it up. So I think that's the future, transparency in medicine. You know, if surgeons are getting bad results, it's not for the patients to suffer. It's for those surgeons to be identified and then to undergo the necessary training to get them to the level that they need to be at.
And perhaps another criticism of robotic surgery is that it can take a lot longer sometimes. What do you think this is a product of? Could it be that actually people are being much more careful because they know that they're being monitored constantly? Is there an equilibrium point here? Because obviously longer surgery is more time under anaesthesia as well. There's a balance to be had.
I mean, there is an absolute balance. I'm equally fearful of overly fast surgeons too,
of course,
because they can also get themselves into a lot of trouble. We look for an optimum time. So by collecting telemetry, by collecting the database, I will know what the learning curve is, and I will know what the average length of an operation should be for a large body of surgeons. So that gives us a benchmark, which at the moment we don't fully have. To set up our robot, it takes no longer than normal laparoscopy. And we've tested that multiple times in the laboratory and in real time in human surgery. And to take it down is equally quick. And if we had an emergency and needed to open the abdomen for whatever reason, we can get the robot out the way in about 20 seconds. So it's not going to inhibit it. So no, I don't think it will be longer. In fact, I think it's going to shorten surgery. I just see more advantages coming from it.
And another interesting potential future avenue for robotic surgery, we're currently sitting about a metre away from each other. But is there a prospect for surgeons operating far more remotely, say, and actually improving access to some of the best surgeons in the world, maybe 1,000, 2,000, 3,000 miles away?
Okay, so there's a yes and a no answer to that one very, very clearly. In the first instance, having a surgeon sitting 100 miles from the robot, there's a problem called the speed of light, and we can't alter that in any way. And when your lag gets to about 100 to 150 milliseconds, you would have a visible lag on the screen compared with the surgeon's hand movement. So the surgeon has to then use a technique called move and wait. And that's clearly not perfect. Now,
much like the Mars rovers.
Exactly. And so there was an operation done between New York and Strasbourg by Robotic minimal access surgery. And I know the doctor that, the chap that was one of the design team for the Da Vinci was involved in that. And they achieved that by laying a cable from theatre to theatre, $30 million. So it was a monstrous marketing display. So no, that's not the case. And of course, that's where the original robot was developed for. They thought you could have the surgeon sitting safely while the patient was being operated on in the battle zone. There's a degree of naivety about that. However, on the other side, you made a very important point about access to some of the best surgeons. So what the whole robotic platform and having a console makes possible is that you can have remote teleproctoring. So I could have a surgeon in New York who could watch over a video link and give me advice on what I'm doing correctly. So he might have, or she might have done a couple of thousand cases, and I'm starting out, I'm only into my 10th, and I hit a problem. We could ring them up, and they would look at it and say, oh, if I was you, I'd go here. And there's already systems that you can do image overlay, so they can put their hand on a trackpad and point to me and show me where they would do something differently. So the lag is not as important there. It would be discussional, and it would be giving me advice and help. So that already is and it's something that's already being done in Norway, in the northern hospitals, which are difficult to get to and from in the dark winters. Those surgeons send their tapes down to be mentored by surgeons in the main teaching hospitals. So I see a lot of that there. But actually, operating at a distance, I'm certainly not going to be operated on when the surgeon's not in the same room.
I think if you wouldn't be operated on as the co-founder of a medical robotics company, I probably won't be as well.
Absolutely.
And I think one final question, just to end with. You mentioned the prospect of potentially autonomous suturing as well, and we may be looking quite a long way into the future, but do you see a greater role for perhaps supervised robotics where actually the surgeon is hands-free, hands-off?
I think that's a long way off at the moment. I mean, if you look at the difficulties with facial recognition, there's no system that's perfect. There's still a high degree of false positive, a high degree of false negative. You look at it in histological examination, and I saw a great example the other day where they've got a remote system for taking photographs and enhancing them and magnifying them to get histological diagnoses. And they'd got up to about a 98% sensitivity with the system, when they realized that one of the things that the computer was recognizing was the yellow ring that had been painted around the suspicious lesions. And once the surgeons didn't ring the thing, the system wasn't as good as identifying it. Do you know what I mean? So I think we're a long way there. And, the anatomy is so complex. The anatomy also moves. So your liver moves by 4 centimeters with respiration. So I don't think in my surgical career we're going to see autonomous operating. Well, I hope not anyway. And but who knows in the future? We've come such a long way so quickly that we will see elements of surgery automated. And areas that I sort of anticipate that being more are things like neurosurgery, where your skull is a fixed size, your brain is an immobile organ. You can fix the head on a theatre table, and then you've got all the advanced imaging, so access, routes of entry, and precision biopsying and so on. I see all that as just around the corner.
And combining scans in real time as well.
Absolutely, yeah. And again, the difficulty in the abdomen is combining scans in real time is movement. But I'm sure we'll get over that. And as you know, our company, one of our investors is General Electric. And clearly one of their interests is them working with us in combining, their imaging with our surgical tools.
Very exciting future to look forward to. Dr. Slack, thanks so much for joining me today.
It's my absolute pleasure. Anytime. Cheers.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think. Do leave us a review on Apple Podcasts if you have a moment, and you can also reach us via our website and our social media pages.